Good afternoon. My name is Sue Stewart. I'm the Executive Director of BMT Infonet, and I will be your moderator for today's session. Today's workshop is entitled Ask the Transplant Expert. And before we begin, I'd like to thank Pharmacyclics, an AbbVie company, and Janssen Biotech Incorporated, as well as Kite, a Gilead company, whose support helped make this workshop possible. It's now my pleasure to introduce to you today's transplant experts. With us are Dr. Mohamed Hegazi, Dr. Gerhard Hildebrandt, and Dr. Navneet Majhail. Dr. Mohamed Hegazi is an assistant professor of medicine and co-director of the Blood Cancers Cellular Therapeutic and Transplant Program at the University of Louisville James Graham Brown Cancer Center in Louisville, Kentucky. Dr. Gerhard Hildebrandt is a professor of medicine at the University of Kentucky and division chief of the Division of Hematology and Blood and Marrow Transplantation. Dr. Navneet Majhail is deputy physician-in-chief of blood cancers at Sarah Cannon Transplant and Cellular Therapy Network. He also serves as the director of the Sarah Cannon Transplant and Cellular Therapy Program at TriStar Centennial in Nashville, Tennessee. This workshop is devoted entirely to questions and answers. If you have a question for our panel of experts, please type it into the Ask the Question box on the left side of your screen, and our panelists will answer as many questions as time permits. So let's get started. First question, Dr. Majhail, I'll direct this to you. I had a stem cell transplant 3 years ago. My DCI chimerism CD3 is the only one that is not 100% donor. Will this eventually get to 100%? If not, does it make it more likely for me to relapse for an ALL? Is there anything I can do to help convert it? I am blood type B, donor is O. My blood is still B. That was a long question.
Yeah. Thank you, Sue. First, really excited to be here and to interact with our colleagues and patients as they participate in your workshop. So for these questions you've just asked, since there might be folks in the audience who do not understand some of these terms, very quickly, when someone gets an allogeneic or a donor transplant, one of the things that we do to monitor how the donor cells are engrafting and working is we'll do a blood test, and sometimes from the bone marrow as well, where we'll check for what % of your blood cells are donor versus you. And that is what chimerism means. And CD3 is basically one specific cell type amongst the many others that we can look at sometimes to tell us what compartment of the donor cells is you versus the donor. So first, congratulations for being 3 years out. I mean, that's pretty incredible. So that's a pretty big deal and very nice to hear that. And what it seems is, and again, without knowing the details of your case, what seems to be happening is, we desire and we want, especially in the context of people with cancers, that all the cells in your bone marrow end up being donor-derived, so they are 100% donor, because we feel that ensures a good autoimmune response, immune response that keeps you protected from leukemia relapse. So again, I'll encourage you to talk to your physicians to see if there's anything else that needs to be done to make that 100%. Having said that, once in a while, for whatever reason, we'll accept that and live with that, especially for someone who's 3 years out, given that your chance of leukemia recurrence is very low. And in some occasions, we can do other interventions like give you cells to make it come up to 100%, but there are risks involved with that. So again, it's a risk-benefit discussion where we may try to push that number to 100%, and like I said, sometimes we'll just accept that given that you're this far out.
All right, thank you. Dr. Hildebrandt, I'll direct this question to you. How common is it to still be dealing with GDHD issues 5 years out after an allo transplant?
So first of all, thanks for the opportunity to be part of this symposium. That is a very good question. It depends a little bit if you had graft versus host disease before. I always tell my patients who live beyond basically the first year that about 50% get a chronic graft-versus-host disease roughly. 5 years out, if you never had chronic graft-versus-host disease, I think the chances are rather low. But there is always the risk if you have certain situations which could trigger basically a flare. Some we do understand, some we don't understand. I give an example. If you don't have chronic graft-versus-host disease at 5 years, but you basically go sunbathing, which your doctor should have advised you against, and get sunburns, you could trigger an immune reaction, which at that point could initiate chronic graft-versus-host disease of the skin.
All right, thank you. Dr. Hegazi, I'll direct this to you. Does the immune system ever come back to full strength after transplant? I'm 9 years out from my BMT, and I'm still told I have a compromised immune system.
Thank you very much for the invitation as well, and thanks for the colleagues. And to answer this question, it really depends. It's an excellent question, but it depends on multiple factors. Is there any chronic GBHD going? We typically monitor immune reconstitution as the months and years pass post-transplant. If we assume that there is 100% no evidence of any acute or chronic graft-versus-host disease and the patients continue to be not on any type of immune suppression, the patient's immunity does grow, and that's when we believe that at 2 years they can receive live vaccines, for instance, with the measles, mumps, and rubella, and we see that they are able to perform activities of regular daily living without feeling that they are more immune compromised than others, because we believe that cases of graft versus host disease is also, it is not just that the graft is attacking the body, but it's also a case of immune dysregulation where those patients are considered compromised and certain type of prophylaxis is needed for them. So it really depends. It's a nice distance from transplants you mentioned, but it really depends on the condition of the patients in general and where are they to tell if their immunity has fully reconstituted and they are not quote unquote immunocompromised anymore or not.
Thank you. Dr. Majhail, are cognitive challenges a common issue 3 years after an allogeneic transplant? This individual also had 2 brain surgeries and a brain bleed in 2019 and an aneurysm in 2021, if that helps with your answer.
Yeah. So are you asking clotting issues being a challenge 3 years out?
Well, she's asking whether cognitive issues are common 3 years after transplant.
Cognitive issues. So I would say it is not uncommon to see some cognitive issues for people for many years out. So again, stepping back a bit here, if you think about what our patients go through, both in terms of induction chemotherapy, which are, especially if they have leukemia or lymphomas and whatnot, and as you go through the transplant process as well, especially if you get total body radiation, I mean, it can impact your cognitive function long term, and it's not unusual for some patients to talk about what they call a chemo brain, and I think it's a pretty well-known entity that we've all recognized. And we also recognize everyone doesn't get it. We also recognize that there are conditions that predispose you to it, maybe that may include like how old you were coming into this process, how much treatment you've had as a part of this process. I mean, you mentioned this particular individual has had some other issues as well, such as a stroke and whatnot. So all this can contribute to the problem of cognitive issues long term. And again, I think sometimes what happens is it does get better over time as well. And if anyone is having any significant cognitive issues, it might be worthwhile to talk to your colleagues and your physicians and see if there might be the opportunity to get some neuropsychological testing and referral to see what may be ways to to get around that and adapt to it.
All right, thank you. Dr. Gerhard, this individual indicates that it's almost a year since her stem cell transplant. She has mild to moderate eye GBHD, a mild liver GBHD, mild esophagus mouth symptoms, and moderate skin GBHD. She's scared to get sick, COVID and so forth. What general recommendations do you give patients about traveling, interacting with children, not her own, and interacting with other people while they have GBHD?
So that's an excellent question. The recommendation depends on several factors. I think most of all, the level of immunosuppression the patient is on. If the patient is on a severe several drugs on immunosuppression, 2-3 drugs, I would always advise caution. For travel guidance, I always advise my patients to be up to date with the vaccination recommendations and have basically the vaccines received and completed per guidelines. For interactions with other people, again, I think that really depends on the level of immunosuppression. Of course, if someone is sick, raise caution. I do think that we cannot lock our transplant survivors up. They cannot live in a vacuum or in a bubble. For other like specific situations, for example, now in the times of the pandemic, I think it's important to talk to your transplant doctors. And for example, if you haven't received it, get like an antibody boost for COVID, like Evusheld if you're on immunosuppression, things that can be done to help here. Navneet, you I think did a lot in that area too. You want to weigh in?
Yes, certainly. Thank you, Gerhard. And I think when I talk to my patients about travel or the precautions they need to take, especially once they're more than 3 to 6 months or so after their transplant, I talk about the concept of risk mitigation, right? So all of us have risks for getting things like infections, whatnot, as we travel, see family. And what impacts or what happens to you in specific as an individual depends on what's going on with you post-transplant. Do you have graft versus host disease? Are you still on immune suppression? How much immune suppression are you on? I mean, is there anything else going on that might compromise your likelihood of getting COVID or something else, for the instance, right? So everybody is very different. So talk to your physicians, but at the end of the day, it's all about how do you get a sense of what your risk is and how do you mitigate it, right? So even if you have GBHD, if you're on immune suppression and you want to go and visit some close family who understands what you've gone through and they're masking, they're washing their hands, they're being careful, you're driving down, I mean, that's one risk versus that same individual with that same severe GBHD trying to go to a football game or something where people may not be masked, right? So I think that's where you have to understand what your own risks are and how do you come up with a plan to mitigate them.
All right, thank you. Dr. Hegazi, I'll give this one to you. This woman is 28 years post-allo BMT. She relapsed. She had a donor leukocyte infusion 26 years ago, and she's wondering whether there's a possibility that the stem cells will be exhausted and she'll relapse again. Can you comment on that, please?
Yes. First, I would like to congratulate her on 28 years post-allo transplant. That's wonderful. The stem cell exhaustion is a topic that we read and discuss regularly. There is, a spectrum when the immune system is reconstituting, and parts of that spectrum can be augmented with certain therapies, such as what she received as donor lymphocyte infusion, with the thought of lymphocytes that has grown in a different environment might be more immunogenic against the relapse, which seems to be a success for 26 years now in her case. the matter of monitoring the function of those of the transplant, and it gets simpler when we are much further out from the transplant, as you have already established from your monitoring of chimerism and the other markers of immune reconstitution, the levels of those different types of cells, and you have tested them with vaccines to get the body back up to speed with its ability to fight infections. It really depends on the current state and function of the graft with an assessment, and it's not a one-time. It's a spectrum, as I mentioned, that you monitor over the many years, and you see if there is any fall down in certain markers or certain lineages as you evaluate. I would like to hear what Dr. Hildebrandt and Dr. Majhail would comment on this topic as well.
Doctors, have any additional comment?
Well, I think actually, go ahead.
I would say I think at 28 years, the likelihood of the leukemia coming back, irrespective of exhaustion, is almost negligible. That's all I would say at this point.
Okay. All right. Dr. Gerhard, I'm going to give this one to you. Can GBHD cause neuropathy in all the different nervous systems, autonomic and parasympathetic and central, as well as the neuropathy we can feel peripherally?
So that's a good question. There's certainly the concept of a central central CNS graft versus host disease. So the cognitive defects could be the result of graft versus host disease in addition to toxicity. There is actually animal data which has shown lymphocyte infiltration into the brain. So there's certainly a certain chance for graft versus host disease directed against the brain. It's never been really proven to like the mechanism is not fully understood. Let's put it this way. But again, animal studies have shown this. The neuropathy after transplant is probably more multifactorial. It's always important to work with your doctor on the medications you take. Many of the medications we use have a neurotoxicity, temporary, some permanent. Vitamin deficiencies could contribute. So I do think it's really a difficult question to answer one fits all. It's really it needs a thorough workup to make sure what is going on with the nerve system.
And I might add, later this week, I believe it's on Wednesday or Thursday, you can check your agenda, there will be a separate session on neuropathy, and perhaps that physician can shed some additional light on that as well. Dr. Hegazi, does low IgG after transplant increase the risk of secondary cancers? This person gets IgG infusions every 4 months or so as her levels drop.
So prolonged hypogammaglobulinemia, which is chronic deficiency in IgG production, can be associated with recurrent infections on the short term, and as the infusions go, it would help with reducing that. There is certain malignancies that has been reported to be associated with a decrease in with a chronic prolonged hypogammaglobulinemia. That comes. Some of them are cutaneous malignancies like skin cancers, and then some also are T-cell related, amongst others. A prolonged chronic hypogammaglobulinemia is not an uncommon thing, and in general, monitoring or infusing it is really dependent on the clinical scenario. I don't always give immunoglobulins to patients who have a low immunoglobulin unless they are suffering from consequences such as recurrent infections.
All right, thank you. Dr. Majhail, how common is it for transplant patients to have increased dental cavities after transplant. This gentleman went through transplant as a teen, previously had good oral health, but in his 20s had multiple dental cavities despite taking meticulous care of his teeth. He's also not sure if it's related, but he was recently diagnosed with osteoporosis in his 20s and wonders if that too is common after transplant.
Yeah. So both dental cavities and osteoporosis are a known what we call late effect or late complication that happens in our patients who undergone a transplant. And in fact, for dental care, our guidelines to recommend that our patients see a dentist at least once a year after their transplant. And if they have graft versus host disease of the oral cavity mouth, that they see a dentist at least every 6 months. So again, that's a known side effect of the transplant process. And the same thing with osteoporosis. And I think we're coming to the recognition that all patients should possibly get a DEXA scan once they're 1 year out, irrespective of their age. And if there are any concerns there about bone health, then continue monitoring that long-term as well.
All right. Dr. Hildebrandt, this individual has GBHD of the skin and eyes. She's on sirolimus and wants to know if sirolimus affects her eyes.
So sirolimus itself, I am not aware that it directly affects any eye, causes eye issues directly. I'm not aware of this. I don't know if the others are aware of any direct toxicity of sirolimus on the eye.
I wonder if she meant sirolimus work for the eye, GBH. Is that the intended question? Because you know, I'm unaware of any consequences or harm from the sirolimus. But for GBHD, I don't typically use the sirolimus if it's eye and mouth only.
All right. Dr. Majhail, if a post-BMT patient has had monoclonal antibodies when they had COVID, should they have repeat monoclonal antibodies and or Paxlovid if they get COVID again?
So it's a good question. The answer is we don't know. I mean, the monoclonal antibodies are supposed to stick around for 3 to 6 months, technically, right? And if you're beyond that time period, then I think you could possibly use either of those approaches to cut down the chances of getting severe COVID in that context.
Okay. Dr. Hegazi, go ahead.
I think just for the monoclonal boost with UofL, I do think that now there is the recommendation after 3 to 6 months to consider repeating it, to my knowledge, if you get it after transplant. So I think the current and the changes, unfortunately, all the time with all the advanced knowledge we have, but I think it's within the first year after, or first 1 or 2 years after your transplant, you can get UofL, which is a COVID antibody, and then you repeat this after 3 to 6 months. It gives you basically a passive protection against some strains.
All right. This one person wants to know, and I'll throw this out to whoever would like to answer it, whether GDHD causes you to be fatigued.
I think anyone from us probably can comment on easily. So graft versus host disease makes you fatigued. I think that's one of the classic symptoms. In the acute setting, one of the leading cytokines historically is TNF-alpha. It's a kind of a cytokine which drives inflammation and also was called for a while the wasting syndrome cytokine. So you do get fatigued, and again, this fatigue is multifactorial, but I would say all my chronic graft versus host disease patients say they're fatigued.
All right. Dr. Hegazi, this individual is fair-skinned, has had several basal cell cancers removed over the years, but never had squamous cell. Since his autologous transplant 4 years ago, he had several squamous and cancers removed. Other than skin checks every 4 months, is there anything else he can do?
That's a common question that I get. Definitely immune suppression is, in general, the immune system, when it's fully reconstituted, it has this checkpoint inhibition of any growth of malignancies. When we suppress our immunity, that chance of having secondary malignancy, especially in the skin, goes up. And my patients, I typically talk to them about how important is sunscreen and protection, and I always tell them it's always easy to remember to put it before you go out, but those things don't last all day, so try as much as you can to reapply them when the period of time that they last is past, and also try to avoid sun exposure as much as possible. These are the things that I usually talk to the patient about. It's always about prevention and attempting to protect your skin from any secondary exposure to radiation from the sun on the regular. I think if a patient has a recurring squamous cell carcinomas that are shown regularly, further evaluation to look deeper into the situation and make sure that there is nothing else going on that is leading to these skin cancers to be popping.
Well, thank you. Dr. Majhail, if you're on immune suppressants when you get your vaccines, and you continue to be on immune suppressants, specifically Jakafi and tacrolimus, are vaccines effective? And can this person travel internationally while on immune suppressants?
Yeah, so I think there are two aspects to the questions you just asked. So the first is, how effective are vaccines in the context of ongoing GBHD therapy? And I think the answer to that is it depends on the intensity of the therapy you're on. So typically, if you're on very high doses of steroids, for instance, we might delay vaccines by a little bit to let those doses come down before we vaccinate you. Now, if you consider Jakafi and tacrolimus, and if you consider the extent of immune suppression that happens with Jakafi and tacrolimus relative to things like high-dose steroids, or some other immune suppressants, it's more relatively moderate. And I would imagine that the vaccines will hopefully be effective in that context. And in fact, if we look at the guidelines that are out there about vaccination, and with the caveat that they are being updated at present, the guidelines do recommend even patients with active GBHD get vaccinated, even though there's a small chance the vaccine efficacy may be not as good as someone with fully recuperated immune system. And the reason for that is we recognize our patients with GBHD are the ones who are most prone to these vaccine preventable diseases. So the short answer to the first question about tacrolimus and Jakafi or ruxolitinib, again, hopefully, you did respond, and in most instances, we would recommend vaccinating in that situation. Now, the second question was international travel, and I think it's less of a question of tacrolimus and Jakafi. Earlier on in this call, I talked about the concept I tell my patients, that is risk mitigation. So it all depends on that, right? So where you're traveling, how far do you have to go? Will you be flying, for instance? And if you're flying, what is the distance and whatnot? So I think if you're on tacrolimus and Jakafi, I think these are some of the things to consider as you think about international travel.
All right. Dr. Hildebrandt, how many lines of immunosuppressant is advisable to aggressively treat GDHD? My doctor will not put me on more than 2 lines of treatment at a time, but I know other patients who are taking 3 or 4 at the same time.
That really depends on I think the severity of the graft-versus-host disease, which treatments have been tried already, which combinations have been tried. I don't think there's an absolute limit for to basically drugs, or how you say when you want to call it, lines. Usually we use lines for first line, second line, third line sequentially, but we add on, and if you call the second, third line, there is no limit. Some patients are certainly on three drugs or approaches at the same time, sometimes even on 4. The problem is the more you immunosuppress a patient, the more you also run the risk of side effects like infections. I mean, also, I have to say you have to be cautious as a transplant physician when you combine these drugs, and we don't know exactly how the interactions might be. So if the mechanisms are compatible to combine, you can combine, but I think that's a really a very complicated question, and there's so many factors which come together here. But no, I don't think there's an absolute cutoff of 2.
Very good, thank you. Dr. Hegazi, excuse me, are regular testosterone shots, hormone therapy, a good therapy for transplant patients?
Honestly, I have to be clear here. When it comes to testosterone, I always consult with my endocrine colleagues and have them rule this part. I check the levels, and if I see it low, I send the patient and have them make that judgment in that topic.
All right. Dr. Majhail, can IgG increase the severity of lung GDHD?
So IgG level by itself should not have any association with GBHD whatsoever. Well, the only thing that can happen is sometimes in patients with GBHD, more so because you're on immune suppressants, the levels can be low, but a high level is typically inconsequential.
Okay. Dr. Hildebrandt, will GBHD increase the chances of a secondary cancer or the alloimmune cells? Do they have the problem of taking care of the potential of future cancers beyond just leukemia?
So that's really probably 2 questions. Graft versus host disease. We do know that there's a graft versus leukemia or graft versus tumor effect, which basically reflects the donor immune system exercising kind of an immune surveillance against either the initial cancer or maybe to emergent secondary cancers, but that is very hard to track how many secondary cancers theoretically would have been prevented. The secondary cancers in transplant survivors and also in patients with chronic graft versus host disease are increased, and that probably is more as we said earlier, the consequence of a defect actually in the immune surveillance secondary to immunosuppressant. So chronic immunosuppressant use increases your cancer risk. For example, tacrolimus skin cream have been associated with skin cancers. Jakafi is associated with spinocellular carcinomas of the skin. So there are treatments we use to treat chronic graft versus host disease, which then actually increase your risk of secondary malignancies. Also, if your immune system is suppressed, the innate or the inherent is probably the better word, immune surveillance of the police we have as humans in our body to eliminate emerging cancer cells is reduced. All this results to increased secondary malignancies in transplant survivors.
Thank you. Dr. Majhail, this individual is nearly 12 years post-allo transplant. At 5 years, she had a vaginal tumor that required both radiation and chemotherapy, including cisplatin, which has caused a moderately severe vestibular weakness. During other routine tests, it was discovered that she now has MGUS, which she's advised to not be concerned about as it's not currently a concern. She's wondering if this MGUS might be related to the transplant, and whether or not it is a concern, i.e., could she be developing multiple myeloma?
So the MGUS is, and again, for the benefit of other patients on the call, MGUS is what we call monoclonal gammopathy of unknown significance, and it's basically a type of blood cells that will sometimes start producing a protein, and if there are too many of those cells and those proteins are causing damage, it can cause this other blood cancer called multiple myeloma. So again, as we think about second cancer studies and research that has been done in the context of our transplant patients, multiple myeloma is not a cancer that typically stands out as being particularly associated with the typical exposures like chemotherapy and radiation, although it could potentially happen, but it's not a very common or well-known event. It's rather rare. And the second thing I would say is in this context, as people grow older, they are prone to having MGUS in general. So there might be an age factor involved that might be independent of the underlying transplant. Although, again, I have to acknowledge the transplant, it is possible may have contributed. Now, with respect to the chances of getting multiple myeloma, I mean, everyone with MGUS does not develop multiple myeloma. Overall, I mean, it depends on a variety of factors, and I'm sure he or she is following a hematologist or a hematologist oncologist who can counsel the patient on what the risks are and how closely someone needs to be monitored so that in case there is the tendency of moving towards multiple myeloma, treatment can be started sooner than later. And again, I want to emphasize most patients with MGUS do not develop multiple myeloma. It's something we keep an eye on, and very often it stays stable or may slowly increase without getting to that myeloma stage.
Okay, thank you very much. Dr. Hegazi, this individual wants to know if there are any reasons why you might not give somebody IVIG if their immunoglobulins are low. Are there risks that would mitigate against that?
Well, IVIG is a therapy. Every therapy has its own side effects, but I always look at what's the benefit of what we are giving. If the patient is having low immunoglobulin level, but it's not low enough to be causing the patient any consequences, it depends on like what is low. So sometimes patients would be, what I look at is like if their immunoglobulin level, IgG, is like less than 400, and they're having recurrent infections, I do give them immunoglobulins. But if they are less than 400, but they are living a normal life and they're not having any recurrent infections, I don't see a necessity. I know that some might go to a lower limit and say if it goes below this number, let's say 200, I would give IVIG regardless to prevent any serious consequences, and that's a point of discussion. It's always, we have to remember there is a cost to every therapy, not just financial cost, but a potential side effects from it. And we have to keep that in our mind as we do it, because once you start those therapies, it is, it can be a lifelong thing if the level never goes up on its own through the immune system.
Thank you.
If I can just weigh in too. So I think it really also depends if the patient. First of all, of course, like Dr. Hegazi says, recurrent infections trigger IVIG replacement. But if patient have a chronic graft-versus-host disease and are on immunosuppressants and have a low IgG level, for example, below 200, in our program, for example, we do replace immunoglobulins because we do think that not only the component of the immune system, which involves the immunoglobulins, but also based on graft-versus-host disease treatments, maybe other arms of the immune defense are weakened, the risk is too high.
Thank you. Dr. Majhail, have you seen myalgic encephalomyelitis, chronic fatigue syndrome as a late effect of transplant? This individual had an auto transplant with TBI and was diagnosed with chronic fatigue syndrome after transplant. and is wondering whether the high-dose chemo and TBI triggered the chronic fatigue syndrome and whether there's been any research on this.
So that definitely is a hard one, because typically when we talk about fatigue issues, we typically think about our allogeneic transplant survivors who have active GBHD, acknowledging the fact that all patients who have had a transplant do have some level of fatigue, which is not uncommon and unusual. And I recognize BMT Infonet has done several webinars, and you may have another one coming up as a part of this series as well that talks about fatigue in our patient population. So following an autologous transplant, having fatigue severe enough to cause what you're describing would be unusual. But having said that, it is possible, because again, I know we always tend to focus on what happens and what exposures a patient gets around the transplant itself. For example, this individual got high dose total body radiation and chemotherapy. But as patients, as individuals, as I look at myself as well, we all come as a package, right? So that is where what our age is, what our other medical issues are, what other things may be going on with us that might predispose us to something like this. And on top of that, you add the total body radiation and chemo. I mean, that might make us experience something specific, which is otherwise rare. That can happen.
All right, thank you. Dr. Hegazi, should transplant patients have meningitis vaccinations, and if so, which ones and how many times?
So the meningococcal vaccines, we typically in our program start them at 12 months and then give them a booster at 14 months. And currently we have been in review of the different published guidelines, either in Blood, one of the major journals in our field, and other big centers in the United States, where other surveillance with titers, as well as sooner completion of the complete course of a third shot to be giving at 16 months, and then start monitoring the response to the vaccine with titers starting at 18 months. So we in our program currently, this is kind of I'm giving you like the inside of what we're discussing right now in our program, but our current standard, it's still 12, 14, and then 24 months. That's the standard with a follow-up monitoring from there. But we're trying to complete the series of vaccinations sooner, following the not so long ago post-allo transplant vaccinations guidelines published in Blood.
Great, thank you so much. Dr. Hildebrandt, this individual is 8 years post-stem cell transplant, allo transplant, with a 100% matched donor who tested positive for CMV, cytomegalovirus. This person also was tested a couple of years ago for CMV, but never came down with it, and is wondering whether she should continue with routine testing, or is her chance of getting CMV diminished at this point?
First of all, congratulations, 8 years out. I would not monitor CMV in this patient unless the patient has severe graft-versus-host disease and is on a significant immunosuppression. It's so far out, I don't think there's an increased risk for CMV. I think I would just put the chapter CMV, in the back burner and not worry about it.
Okay. Dr. Majhail, this individual wants to know whether you advise seeing a separate endocrinologist to manage fatigue due to tapering prednisone, or just treat as needed with a transplant doctor.
Yeah, so for management of fatigue, that might happen as you're tapering off prednisone. Typically, we tend to manage it ourselves. We don't ask our endocrinology colleagues to get involved in that. So it's only if somebody has managed to go off steroids completely, is having evidence clinically to suggest there might be cortisol deficiencies, that is where we may get them involved. but during the tapered process, we tend to manage it ourselves.
All right. Dr. Hegazi, this is a 64-year-old male who's a year and a half post-auto transplant for multiple myeloma. He's in a stringent complete remission and on, I'm going to fill this title, daratumumab and Revlimid maintenance. What's the current thinking on the length of time to be on Revlimid maintenance? Is there a controversy on the value of continuing this therapy given the side effects?
I think we're all looking for more data, and I personally believe as much of what we have seen so far is as long as the patient can tolerate the maintenance therapy, continuation of the maintenance therapy might be worth it. Now, with the more and more of our understanding of what we call a measurable residual disease or minimal residual disease, and the depth of control might be leading to going away with maintenance altogether, depending on how deep the disease is controlled. So, I would say we, outside of a clinical trial that tells us that the combination of daratumumab and Revlimid, which we have an ongoing clinical trial for that in maintenance post-auto transplant, one of the cooperative groups, trials that it puts an end on the Revlimid, and we don't know much about comparing longer periods of time, but I believe in general that I would continue the Revlimid maintenance as long as the disease is at bay, because we are still dealing with a disease that is not curable, and prolonging the period of disease control, maintaining him in this stringent complete response that he has achieved, which is wonderful, would have to look at the risks and the benefits of this combination. And as I said, there is data, there is a clinical trial ongoing. We will learn from this clinical trial quite a bit about the combination daratumumab and Revlimid in a more comprehensive approach.
Great, thank you. Dr. Hildebrandt, can skin GBHD present as welts and redness at night that subsides and changes through the day?
I think it probably could. I think skin GVHD can present in very different forms. If it was a regular occurrence at night and disappearance during daytime, I will probably also look into other causing factors, even down to the material of the bedding or the detergent. If there's a regular time schedule, every day at night it happens, but during the day it subsides, that would be rather unlikely. But that redness waxes and wanes, that is possible.
Okay, thank you. Dr. Majhail, this individual said, are there stats on people who are healthy after transplant? There's so much talk about GDHD, skin fatigue, gastro problems, et cetera. It sounds like the illness never ends.
So what I would say is, as we think about graft versus host disease, that is not necessarily the case. So stepping back a bit here, so if you look at all our patients who get an allogeneic transplant, and depending on your donor source, your graft source, a variety of other factors, roughly a third to a half of our patients will develop graft versus host disease. And again, keep in mind, among our patients who get GBHD, there's a whole spectrum of severity that we consider and look at amongst our patients. But amongst all our patients who get GBHD, it'll resolve, it'll get better in roughly 70 to 80% of our patients, or you might need some mild treatment to keep it under control. For the majority of patients who do get GBHD, it does improve and is controllable. It is just a small percentage, 10 to 20%, where it tends to be very refractory to treatment, and you have to be on multiple lines of therapy as well as you go forward. I would respond by saying that, again, it is one of those side effects that we're all, as a field, trying very hard to mitigate and find good treatments for it. It is such a big active area of research across the board. I mean, how do we cut down the risk of GBHD, and also how do we treat it better? But again, for most patients, it does tend to resolve, and it does tend to get better over time.
All righty. Dr. Hegazi, is there an easy way of evaluating someone for T-cell exhaustion?
Evaluating for T-cell exhaustion, I guess it really depends on what's the concern behind it. If we are looking at a patient who is relapsing post an allo transplant with the loss of the graft T cells, or despite their presence, the disease is relapsing. It really depends on the patient's scenario and what is raising that concern, because ideally, we monitor chimerism and we see the percentages of the donor and such. And in absence of any abnormality in regards to the disease showing back up, we are usually worried about making sure the patient maintains not just survival, but also GBHD-free survival. So we are looking at the other side of things and trying to maintain that graft from attacking the patient's healthy other organs.
Okay, very good. Dr. Majhail, are there any immunosuppressants that should be avoided if lymphocytopenia is a problem?
So you have to keep in mind most of the treatments that we use for GBHD do cause, or what we use to cut down the risk of GBHD and prevent it, do cause lymphocytopenia. They do cut down the numbers for your lymphocyte counts, because that's how they work in preventing the risk of graft versus host disease. So it's one of the known side effects or things that just comes with the use of those agents. Now, having said that, I mean, over time, it again tends to get better, and there are certain agents that tend to impact the lymphocyte counts less than others. But I think in terms of making a decision on which of those agents tends to work better for a given patient or not, we typically don't consider the lymphocyte counts necessarily.
All right, thank you. Dr. Hildebrandt, have you heard of GDHD of the tympanic membrane causing sclerotic changes of the tympanic membrane and deafness in that ear?
I personally have not seen it. I would like to see what the other panelists say.
This is Navneet. No, I have not seen it either. I mean, just isolated on the tympanic membrane, no.
All right. Dr. Majhail. Oh, go ahead. I'm sorry.
I was going to say, either I can imagine a severe sclerotic disease involving throughout the patient's, body. I can imagine it, but I've never seen it. But I can see that happening in a severe scleroderma or sclerotic GBHD.
All right, thank you. Dr. Majhail, could monoclonal antibody be given to post-transplant patients to prevent not only COVID-19, but other viral infections too?
So obviously in the context of COVID-19, we have been using different variations of the monoclonal antibodies over time to cut down the risk of infections. But if you think about infections other than COVID-19, typically we do not use antibodies for that purpose. Again, there might be situations such as exposure to certain infections. I'm thinking of maybe hepatitis or something like that, where you can give hyperimmune globulin in that context. But no. So besides COVID-19, typically we don't tend to use antibodies to prevent other infections.
All right. Dr. Hegazi, this one woman says the tip of her tongue is swollen and red. Could this be GDHD?
So there is multiple other missing information to be able to look into that. How far are we from transplant? How does the rest of the inside of the mouth looks like? GBHD can come as redness, inflammation, and swelling. Sometimes it can cause ulceration of the linings of the mouth, and that can definitely get worse and involve most of the mouth. One small part of the mouth, I've had a few who would have that, and mild topical therapy would control it. I always try to look at the patient to make sure it's not also a localized infection that can be taken care of, and that way we can, we don't have to go in the direction of trying to use topical immunosuppressive therapy like rinses and such to suppress it. But can that be GBHD? The short answer is yes, it's a possibility, but more looking into it would help get the exact answer if it is or not.
Yeah, I actually strongly suggest, if this is further out from transplant and not in the acute setting, to also follow up maybe with ENT, just to have them take a quick look to not that this is an early secondary malignancy with an atypical presentation.
All right. Dr. Majhail, I think I will give what will probably be the last question we have time for to you, and it's not an easy one because this woman has consulted with a number of specialists, and they all have opposing opinions, so she's wondering what yours might be. She had an auto transplant and has a normal IgG level, but a very low level of IgA. She has extreme fatigue many years later after transplant, and was wondering whether it would be beneficial to treat this problem with IVIG to help with having extremely low IgA level.
Yes, so again, the response to this partly depends on if there is anything else going on besides fatigue that would prompt a reason to treat the low IgA level. So again, in the context of what we see post-transplant, it's not very often that we see a condition that is specifically related to IgA only. It's more IgG or all the immunoglobulin levels being down. So with this background, I, at least in my opinion, I don't think I would give IVIG just to treat fatigue or an IgA level that is not causing any other specific issues.
All right. Well, thank you. I want to apologize for the people that submitted questions that we weren't able to get to. We had a ton of questions, and I hope that those that the doctors have responded to have been helpful for you. I wanted to thank Dr. Hegazi, Dr. Hildebrandt, and Dr. Majhail for a wonderful session, very informative. And on behalf of BMT InfoNet and our partners, I'd like to thank the audience for some wonderful questions, which I think educated all of us. If you would like to download slides from other presentations or go to other presentations, we encourage you to do so because many of these questions may be answered in those workshops as well. So on behalf of BMT InfoNet, thank you very much for your participation and have a wonderful day.